Dr. Sourav is here. Good evening, everyone. So we are live on YouTube, and I've just shared the link for the YouTube in our chat box so that it can be shared. So good evening, everyone. So we welcome you all to the 10th episode of Late Night Retina. We'll be talking about diabetic vitrectomy today. Dr. Ashish Ahuja will be moderating the session today. He is a consultant at Sadhu Kamal Eye Hospital in Mumbai. He's a vitreoretina surgeon trained from Arvind Eye Hospital. Dr. Ashish, you there?
Yes, hello everyone, and welcome to Late Night Retina episode 10. So, as Dr. Diyvansh said, we'll be discussing about diabetic vitrectomy in two presentations. On the panel, we have Dr. Diyvansh Mishra, who's a vitreoretina consultant at Shankaraya Hospital in Bangalore. Then we have Dr. Sripathi Kamath, who is a vitreoretina consultant at Netra Jyoti Retina Center. Dr. Chitaranjan Mishra, who is a vitreoretina consultant at Arvind Eye Hospital, Madurai. And the first presentation would be by Dr. Sourav Damodaran, who is a clinical fellow at Arvind Eye Hospital, Madurai, who will be discussing about the learning curve in diabetic vitrectomies and what are the challenges. And the second presentation would be by Dr. Dhaivat Vasavada, who is a vitreoretina consultant at Akash Eye Hospital and Ray's Retina Care Clinic in Ahmedabad. I request Dr. Sourav to share his screen and start the presentation.
Good evening all, sir. The host has to enable screen sharing.
Yes, I'll do that. Please continue.
Is my PPT visible to all, sir?
Yes, please go ahead.
Okay, good evening all. I thank Yossi for this opportunity given to me. The topic for my discussion is tips and tricks in diabetic vitrectomy for beginners. So I would like to acknowledge my chief, Dr. Naresh Babu, and my senior consultant, Dr. Hemoglobin, on this occasion. So coming to my case, it's a 65-year-old male complaining of diminution of vision in his right eye for the past 4 months. He had a sudden onset painless diminution of vision, which was associated with floaters. He does not give any history of trauma. In systemic history, the patient is a non-case of diabetes mellitus and ischemic heart disease for the past 6 years, and he is on medication. In past history, he has had a history of laser photocoagulation in his left eye. Coming to the ocular examination, his best corrected visual acuity in right eye was finger counting closed face with accurate PR, and in left eye it was 6/12. Lids, conjunctiva, cornea, and AC were more or less within normal limits. Right eye had a PCAOL in bag with a retrolental RBC, and left eye had an NS2 cataract. Pupil was well reacting to light and was dilating well under pharmacologically. In the right eye fundus, media haze was there, vitreous hemorrhage was present, and no other details were seen. In the left eye, disc was normal, laser scars and regressing new vessels were seen. A diagnosis of both eye PDR, right eye pseudophakia with non-resolving vitreous hemorrhage, and left eye status post PRP was made. The ultrasound revealed an incomplete PVD with subhaloid hemorrhage and minimal VH. So we planned for a right eye pars plana vitrectomy with a tricot wash, endolaser with the fluid air exchange with or without a tamponade. So coming to the surgery, we used a 23 gauge system. So now predominantly the core vitreous is being removed here. So I have a bit difficulty in focusing the microscope here. So due to that problem, I am not going much into the periphery, and predominantly the cutter moves around in the core of the vitreous only. So as I proceed, the difficulty in focusing was added along with the, increasing media haze. So the cutter again just concentrates in the core vitreous only. The media haze increases as the surgery proceeds. So I try to adjust the microscope, and due to the media haze again, I am ending up trimming the vitreous so close to the retinal surface. At this stage, PVD induction is being attempted with the tricot staining of the posterior vitreous. Now the cutter is trying to remove the remnant posterior vitreous. So here you can see the posterior vitreous does not come in toto, but it comes in pieces while using the cutter. So move on to using an extrusion needle with vacuum to pull out the vitreous from the posterior pole in toto. Inadvertently, a break is being created over there in the inferior quadrant. Finally, the PVD induction is completed. Sorry. Finally, the PVD induction is completed. And the remaining vitreous is being removed using the cutter itself. The bleeders are being diathermized here. And also the inferior inadvertent break is also being marked using the diathermy probe. The 360-degree base dissection with the help of indentation is being carried out. BBG assisted internal limiting membrane peeling is being initiated. And the ILM peeling gets completed over here. Post the completion of ILM peeling, fluid air exchange is performed. Endo laser along the breaks, as well as completion of the 360-degree pan-retinal photocoagulation is done. The case was closed under 2cc SF6. So the points to ponder in this case, which would be answered by your experts, are focusing well begun is half done, how to address the bleeders, management of anterior or peripheral vitreous, PVD induction, could it have been done in a better way, internal limiting membrane peeling, whether it is needed or not, tips for doing endo laser, and the choice of endo tamponade. Thank you.
Dr. Sourav, very nicely presented case. So I would like to direct the first question to Dr. Chitaranjan as to how to approach such cases of a vitreous hemorrhage in a patient with diabetic retinopathy. What all points would you look for in the preoperative period?
So in the preoperative period, the counseling is very important. Counseling for the patient and the attenders, especially regarding the systemic status, diabetes control, any associated comorbidities like cardiac or renal, whether the patient is on dialysis, all these things should be taken into account. Additionally, we should give a realistic visual prognosis to the patient, should explain the need of multiple surgeries and the need of multiple visits to the doctor. And coming to the investigations preoperatively, the OCT, P-scan, and with the availability of wide angle fundus photo, the documentation is also even better. Coming to the OCT, OCT is a very good tool, especially in presence of a relatively clear media, where we can document the TRD or say other biomarkers like any damage to the retinal layers, or whether it is a macular TRD or macular threatening TRD or extramacular TRD. For the sake of the juniors, your macular threatening TRD is 4 TD diameter of the elevation of the retina, any part of which is within the 30° of the center of the fovea. So macular TRD and macular threatening TRD, we should go for surgery. Extramacular we can observe because the conversion to macular TRD is less, like 15% in 1 year. So we should observe them. So OCT is very invaluable tool in this. Coming to the B-scan, B-scan is also very, very important, very much time-tested tool, especially in the presence of a hazy media, in presence of vitreous hemorrhage, to locate the tractional retinal detachment, fibrous proliferations, whether there is a broad adhesion or a focal adhesion, whether it is temporal or nasal place. So all these things in the B-scan, and also in payment, they describe one X separate configuration, one H separate configuration, depending on whether it is a focal tenting of the retina due to the attached vitreous, or it is a broad tenting of the retina. So all these things we should take into account, and we should be prepared well. Well prepared is half done. So we should be prepared well for the surgery. That's what.
Yes, these are very good points. And so moving on, in cases of a dense vitreous hemorrhage, and especially for beginners when the media is hazy, it is a good approach to probably clear the vitreous in the nasal quadrant first. Clear the dense vitreous hemorrhage, try to get a view of the retina, because as you keep going posteriorly, inadvertent breaks, even if it happens, will be in the nasal quadrant. So in cases of very dense vitreous hemorrhage, especially in chronic cases, that is one approach. Also, frequent use of viscoelastic may be done in diabetic cases so that the media remains clear.
True. Anything, should I add anything about injections, Dr. Ashish, or you want me to
You
tell
can
something?
mention, you can discuss about preoperative anti-VEGF.
Yes. So shortly, I'll tell preoperatively, all the anti-VEGF injections have been tried and reported in literature, starting from Avastin, our aflibercept, convercept, ranibizumab, even steroids. So everything has been tried, but Avastin remains the most commonly used injection. And regarding the timing, always it has been discussed. The timing they have described as early as 3 days to 13 days after the injection, we should take the patient for surgery. Why? Because as early as 3 days, patients, those who are having more of a fibrous component, they go for a TRD. So 3 days, and average is 13 days. So these injections are given especially to help in the hemostasis intraoperatively. However, we should take care that there is not presence of not the fibrous component is not more, which may inadvertently cause a tractional or aggravate the TR, tractional retinal detachment. So these are the points to take care while considering injections.
Okay, in our group chat, Dr. Kushal has addressed a valid point. Also, what we could do is clear the anterior hyaloid membrane, which is attached to the IOL, under direct visualization first, and then go for wide angle viewing. After inserting the trocars, first doing an anterior vitrectomy, just retrolental space, and then using the wide angle viewing system. And then Dr. Kostov has put a point as to PVD induction in diabetic vitreous hemorrhages. The staining is not needed in diabetics because the vitreous itself is stained with blood. Yeah, that is a valid point. Also, the tricot crystals at times tend to clump and settle on the posterior pole. And the PVD induction is challenging in diabetic vitrectomies. So various ways in which we could do that is use a 23 gauge or a 25 gauge cutter, or a Thanos or a DDMS scraper. forceps may be used, and staining may be done in occasional cases. Even trypan blue is an alternative for staining. So the next question I would direct to Dr. Sripathi. We'll discuss about hemostasis in diabetic vitrectomy cases. How do we control the bleeders intraoperatively?
Yeah, it's an well presented case. Controlling the bleeding, predominantly the thought process of controlling the bleeding is the one which starts even preoperatively. Preoperatively, predominantly, we also look for if the patient is on any anticoagulants. The higher, newer generation anticoagulants, these are the must to be stopped because they cause torrential bleeding intraoperatively. Apart from that, if the patient is on dual antiplatelets, definitely stop the clopidogrel variant of an antiplatelet because this particular one can be more harmful. If he is on ecosprin, if possible, it can be stopped. Aspirin can be stopped. Then it is well and good. Sometimes the physician may not give us an this thing to stop the aspirin. In such a situation, we may have to lower the dose of the aspirin and then take up the patient for surgery. Hypertension is one important parameter. Most of these patients are hypertensives. A good control of hypertension is very important. The other important parameter is these patients are mostly having chronic kidney disease. In such a situation, they will be on heparin assisted dialysis. So preferably a dialysis is done heparin free the prior to the surgery, and so that you decrease the amount of anticoagulative effect during the surgery. A good amount of anesthesia definitely is warranted for most of these patients. Sometimes if the peribulbar block does not work, then maybe a small pocket of tenons can be opened and a subtenon supplementation can be done. Some people also prefer to do the surgery under general anesthesia, though I am not a advocate of general anesthesia per se to decrease the bleed. So control of hypertension and this preoperative good assessment definitely will decrease the intraoperative bleed. Better visualization, now coming to the intra-op thing, the better visualization intraoperatively definitely will decrease the bleeders that can occur intraoperatively. Unnecessarily pulling up the vitreous, unnecessarily trying to induce a PVD when it is not warranted, pulling up the PVD without causing a specific, without particular viewing the particular membrane or the tentacles that are attached to the surrounding retina, predominantly the nasal part of the retina, you are likely to cause small tears or bleeders there. The bleeder, when it occurs over a membrane, particularly when it is occurs over a membrane, it is better to see the membrane first well. Once you visualize the membrane, the surface of the membrane, the tentacles can be seen over the surface of the membrane, which can be cauterized with the bleeders. The point to be noted here is the bleeders here were cauterized by touching the retina directly with the endo, the 25 gauge probe. Preferably, the probe should not touch the retina. There should be a sufficient amount of distance from the retina and the diathermy probe. The transmitted heat itself is enough to coagulate. Bleeders you can divide into two or three types of variants. One is a torrential bleeding, the one which occurs with the arterial or a small venous spurt, or sometimes it is generally a small kind of a ooze that occurs. Cauterizing with the proper 25 gauge cautery on the surface of the membrane before removing the membrane definitely decreases the bleed. It also gives you the advantage that whatever tentacles of the membrane are attached on the either side can also be visualized better. The center part of the membrane contracts and you know the exact plane wherein to insinuate your cutter, which is used for cutting the particular membrane. Apart from that, you can also either with the same cautery probe and see those small attachments of tentacles before you introduced a scissor or a cutter. You can also increase the intraocular pressure the moment you have the bleeder by using raising the bottle height, or you can shift to a 60 millimeter increase in the intraocular pressure so as to control the bleeder. Definitely, one important pointer is never allow the blood to stay there for a longer time, particularly if you have not cleared the vitreous well or if you have not cleared the membrane well. Subsequently, if you leave the blood clot there sufficiently for a longer time, removing the blood and the clot becomes much more messier than removing the membrane. So it is better to address this blood and keep a constant watch at this particular blood, particularly when you are dissecting the membrane. These are my points towards how to address a particular bleeder with the cautery, in particular to this case.
Yes, a very nice points of discussion. I would like to add a few points to this. So another thing we could do preoperatively is, patients on blood thinners or with cardiac history, maybe do their prothrombin time or partial thromboplastin time with bleeding or clotting time to know more of their coagulation profile. Also, certain irrigating fluids like balanced salt solutions contain citric acid, which has anticoagulant properties. So such irrigating solutions should be avoided. Also,
Yes.
there's been some studies which have been done. I think in Arvind also we had done that using chilled irrigating solutions. You keep the irrigating solution in the fridge preoperatively and then directly use it. So what the theory is, the lower temperature irrigating solutions increase the tolerance of the tissues to the ischemic insult, and it reduces bleeding. Dr. Diyvansh, would you like to add some points on hemostasis?
Thanks, Dr. Ashish, and nice case which was presented. I have certain other points also. So, shall I add that and then add to the question which you are, or then add to the
Yes,
answer
yes.
which you want?
Yeah, you
So,
can
first and
discuss.
foremost, being a beginner, always better is to repeat the B scan on the day of the surgery by yourself. Because if we go back and see the B scan images, if we can switch the slide to the B scan images, because I'm not sure whether there is an incomplete PVD. What we are seeing is a bloodline vitreous rather than a PVD. So, so as you can see in most of the scans, so this the right lower one, or the one, two, three, third, fourth scan which we are seeing, it's not actually a PVD. It's probably some bloodline PVD. And again, the first B scan, as you can see, the vitreous is there, and then there is intergel hemorrhage, and then again there is some kind of a bloodline vitreous which is there. So if we would have done the B scan beforehand, we would have identified that actually there is no PVD, but it's more like an intragel hemorrhage. So that's the reason why in intraop we were unable to find because ideally in a case of vitreous hemorrhage in a diabetes, there has to be usually in most of the cases an incomplete or a different kind of a PVD, but in such case it was not there. The next point is focusing, like in cataract surgery, how we have been taught that initially for a section, try to focus at the sclera. So in the initial part of the surgery, you have to focus in the anterior vitreous or the mid vitreous. And as you progress towards the posterior vitreous, then your focus changes. And again, the questions which were raised for the anterior vitreous, if in a pseudophakic patient, yes, we can remove the anterior vitreous or open up the most anterior, the bursa, which is there just behind the lens. But in cases of phakic patients, ideally tackling that anterior vitreous after doing a core vitrectomy would be better. The two small points which I needed to mention is that if you're using a cautery, usually the bubbles which come out of the cautery would stick onto the anterior vitreous, and that would help you identify the anterior most vitreous, and then your chances of lens touch are less. Again, when you do a BBG staining also causes a little staining of the vitreous, the gel vitreous, not the liquefied one, but the gel vitreous. So again, the anterior vitreous may show you a little blue color cloud, which you can remove it. So in phakic patients, ideal would be to tackle the anterior most vitreous a little late. And inducing a PVD, one of the techniques before also I had shown is something which is called as vitreous wiping. So using a Vaxil sponge or elastic sponge, you can use a 25 gauge forceps and cut a small piece, hydrate it, and then use it. So that also acts like a brush to remove the PVD, and it has found to be non-traumatic or atraumatic. And PVD in this case, if you can go to the video and just play the initial or the bit where we have induced the PVD, just go to the point where we have started to induce a PVD. So at this point, see, staining is one of the good options because we are unable to get it. So yes, outside in technique is one of the things, but for a beginner, ideally that has to be avoided once our focusing is not very adequate. As you can see, while suction itself, there can be breaks. So I would try to induce PVD in a very close to the disc manner. And okay, once, yeah, now we would use the cutter probably. Yeah. So this kind of PVD induction should not happen in a proliferative disease. So it's not a case of a macular hole or an ERM where we are just pulling onto the disc and we want all of that chunk to come out at once. In cases of proliferative disease, we know this is a diabetic patient and there can be nails, B-scan is not showing any traction or tractional detachment, but ideally such kind of PVD needs to be avoided. You have to go each and each quadrant or clock hour wise ideally. So you start inducing PVD from the disc and then eat up at one clock hour and then go start inducing at the another clock hour and then go in that quadrant and then like that slowly and gradually continuing in various direction would be advised. And blood clot, as in this case, the blood is not like spurting out of all the bleeders. So we could have increased the pressure and then started to do the laser so that that gives an additional time for the small bleeders to get clotted. And then once the laser is over, it may take around more 15-20 minutes. Until that point, we expect that all the minor bleeders would get a little small clot around it. So ideally, we should not try to remove the clot once we are managing the clot. We have to means circle our flute around the clot and suck only the diffuse blood. So if we are trying to remove the clot, we are trying to remove the plug, which would again cause the bleeding. So avoid that. So those were the points which I wanted to discuss. Thanks, Dr. Ashish.
Yeah, these are very useful points which you have raised. We'll come to the next topic to discuss. So the role of ILM peeling in diabetic vitrectomies, what should be the case selection, and Dr. Diyvansh, would you do it routinely in all cases? What is your opinion?
So yeah, so it's a little difficult answer. So not in all cases. So what I would do is I would use BBG to at least stain and see if I'm seeing any wrinkling or any negative stain. If I see that, then probably I would try to do a very small, limited, probably maximum would be 2 disc diameter around the fovea. And yes, most importantly, because that also helps us to identify secondary membranes if there are secondary membranes which are left over. In young patients, like in type 1 diabetes, I would try to avoid. And if the stain is not showing any ERM or any negative staining, I would avoid. But still, to say I would avoid, in 90% of my cases, I would have peeled it. So I don't know what other panelists have to say or pros and cons of peeling, because it's the more important part of peeling is that it should be done in a very atraumatic way. Yes, as sir is mentioning. Yes. Please, sir.
Yeah, so even my call, as far as the ILM peeling is concerned, is as one way of looking at it would be like as you are entering the eye, you do the complete procedure. Now, what extent is the complete procedure is left to the person who is capable of doing, at what level of procedure is capable of doing it. Technically speaking, if you are confident of doing an ILM peeling and in your hands, if the ILM peeling is atraumatic to the extent possible, I would rather go in and do a complete vitrectomy and do an ILM peeling as well. But there are certain situations wherein I will definitely do an ILM peeling. If you have a small break in and around the posterior pole, particularly inside within the arcades, particularly when you are doing a kind of a membrane dissection, you are having a break there, then definitely I will peel out the ILM peeling. Definitely I will do the ILM peeling. The second point would be if there is a diffuse macular edema. If there is a diffuse macular edema, definitely the patient who have already received multiple injections, triamcinolone or different forms of an injections, then again I would also peel the ILM in such group of patients. The third group of patients is if I have to identify, as I said, a second membrane. So definitely it will definitely help me in peeling out the second membrane with one shot, particularly when I peel the ILM. So these are the small indication subgroup of patients wherein I will definitely do a ILM peeling. But as Diyvansh mentioned, in the present scenario, about almost 80 to 90% of the patients wherein I enter for a diabetic vitrectomy, I peel the internal limiting membrane.
So we had a short, quick poll on the number of doctors performing ILM peeling in our 18 participants currently. So about 64% do not do ILM peeling routinely. And as we discussed, yeah, for selected cases, it may be done. So we move on to the 3D visualization system. Discuss a bit about Ingenuity. Dr. Chitaranjan, would you like to add some points?
Yes, yes. So, first of all, I don't have any commercial interest, but yes, here in our center, we do have the privilege of availability and accessibility of Ingenuity system for all the doctors, including our fellows. So, the advantages, if I can quickly tell, number one is the kind of panoramic, broad view, wide angle view that you see, so that at a time you can see in one extreme what is happening, whether a break happened or another extreme one later is there. So you can have a good panoramic. And second point, in fact, the most important point is about the ergonomics regarding the musculoskeletal pain and all, which is a very, very important point because vitreoretinal surgeries are very long duration surgeries, and this system with the heads up system, it helps in decreasing the neck pain and back pain and all. Third is it helps in the, especially in the teaching institutes. If as a senior you are operating, you can show it to your juniors who are standing nearby, no need of the side viewing system. Or if your senior wants to guide you, in fact, with Bluetooth system also, he or she can sit a distance and without making the patient anxious, they can guide you. Additionally, some filters thing also that has been discussed in the chat box. Yes, filters are there, and you can use the filters to see the pictures. So, but yes, if you are having Ingenuity, it's good. If you are not having also, it is. It's not that it's a must, but it do give some advantages. Yeah.
Ashish, can I ask Chitaranjan a question?
Yes, yes, please, sir.
Yes,
Yeah,
yes.
Chitaranjan, if you have to say what is the single most advantage of a Ingenuity and what is the single most disadvantage of an Ingenuity?
Single most advantage will be the ergonomics. Disadvantage will be, can I make two? One will be the
Yeah.
cost factor. Second thing is a little learning curve. For example, ILM peeling we are discussing. So whenever we do ILM peeling, the depth perception, initial periods, initial few cases at least, we have to have that kind of perception and everything for that depth perception. These two things I have personally felt, and the best thing is ergonomics. It definitely kind of gives you this thing,
Nice.
your neck relaxation and all. Anything you want to add, sir? That's Sripathi.
No. I have no experience with Ingenuity. So.
Okay, there is a question in the chat. Any of the panelists could take this. Any role of IVTA in controlling active bleeding?
Uh, IVTA, Ashish, can I take a part of that question?
Yes, sir.
The IVTA, I have been presently doing a study wherein to decrease the post-operative vitreous hemorrhage, in the sense the post-vitrectomy recurrent hemorrhages, to inject IVTA at the end of the surgery. And I have completed about 20-25 patients. The amount of the bleeds, what you see, and the amount of media clarity is much better in the patients who have been injected IVTA at the end of surgery. So IVTA, apart from having an anti-inflammatory effect, it definitely has a certain role in decreasing the post-operative haze. And even intraoperatively, particularly in areas where you cannot cauterize and things like that, particularly in the areas where there are small membranes over the disc which constantly ooze. These IVTA crystals, when they settle on the disc and the membrane around, they also have some kind of an hemostatic effect. I don't know, it has to be scientifically studied.
So just to add, as sir is telling, the evidence is that it acts uh, in the coagulation cycle. So that's how the all the coagulation factors are activated because it acts as a foreign body, and that's how it causes that activation of the coagulation pathway, and that's how the coagulation is better. As sir told, for the disc bleeders, yes, it can be utilized where we keep it for some time and then the disc bleeders decrease. But other methods like mechanical pressure, increase the bottle height, weight, those things can be done.
Okay, so
I
we
had
had
one more question on the visualization of nasal retina. So the nasal retina is the one predominantly nasal and inferior nasal part of the retina, like what Sourav has had the problem. I think those are the very common areas where you can intend to have breaks, because the visualization, lasering that part of the retina, removing the membranes in those particular area, all those things are a little challenging. So generally one other factor is by positioning the head maybe a little to the temporal side. It also helps, particularly in patients who have a prominent nasal bridge, and placing the ports a little on the temporal side also gives you a very good access to the nasal part of the retina. So these are the other small modifications which you can do, particularly when you have problems in visualizing the nasal retina.
Okay, so now we'll move on to the second case. This case would be presented by Dr. Diyvansh Vasavada, and he'll be presenting a case of a diabetic tractional detachment.
Is it visible?
No,
Hello.
not yet.
Yeah. Now is it visible?
Yes.
Yeah. Yeah. It's pleasure to be a part of this UC session. So many of the times, what we expect in reality, but it turns out to be different in actual scenario. So that actually happens when we are dealing with diabetic cases. So to keep calm and expect the unexpected, that should be the motto while performing diabetic vitrectomies. A 68-year-old diabetic male presented to us with complaint of defective vision in his left eye since past 1 month. On presentation, he had a vision of counting finger 1 meter, and this was the fundus picture. As you can see, there was a fibrovascular polyp almost covering the posterior pole with traction retinal detachment involving the macula. Considering the him as a treatment naive, what we planned was left eye intravitreal anti-VEGF in the form of Avastin and 5 days followed by fast runner vitrectomy. Right eye was 6 by 12 and having PDR, we considered for ERP 3 sittings. So we initiated with standard 23 gauge fast runner vitrectomy. We are doing cone truncation to relieve the bridging adhesions anteriorly and posteriorly. After doing almost 360-degree truncation, we are trimming the fibrovascular polyp from its anterior margin. Then with the higher magnification, we are trying to have a plane with the cutter and trying to segment the membranes individually. Yeah, it was difficult as the membrane was quite sticky and adherent to the disc. So we're trying to have a little pull, gentle pull with Alcon Max Grip forceps on the superior part. As you can see, gentle pull to have a better approximation for the cutter. So we are dealing very near to the retina. So one thing to be taken care in the mind that anytime the retina can be endangered. So it should be very gentle maneuver. Furthermore, it was still sticky, so we are just giving a little pull once again, and just to have a better approximation for the cutter in trying to segment it as much as we could. So the thing to be kept in mind while doing diabetic vitrectomy is, unlike REGARD, like we should be not that much aggressive to remove all the fibrovascular polyp until unless it is threatening the macula. So we tried to remove almost all the possible polyps. Yeah, as you can see, the macula is looking fairly okay with pigmentary changes over there. We're doing endo laser in the periphery, mid periphery, as well as around the fibrovascular polyp, as the traction element has been relieved. Doing fluid exchange, and finally ending the case with filling 1300 silicone oil. So this was the post-op picture. Initially it was like this, and we tried to eliminate all the possible traction. The post-op picture was like this. What was not expected was this. So there was a iatrogenic break which we encountered at the end of surgery, which was noticed in fact at the end of the surgery. So we had to go for oil which was not planned earlier. 2 months post-op, the patient is maintaining reasonably decent vision in the form of 6/36. Eye is oil-filled with stable laser changes of retina. We are planning silicone removal after 2 months. So few surgical things which came into my mind was, although we tried our level best to have a gentle maneuver, but further, fine gripping or movement could have been helpful. Use of scissors, especially for delamination. Many of the surgeons do prefer curved scissor for delamination. We used to use, but nowadays we have stopped using. But yes, this case probably would have been done in a proper manner if been done with a scissor. Bimanual approach, like what we have limit our cases in, especially CRD cases, where we start our plan with bimanual things. But yeah, that is one thought by few of the surgeons. For tamponing agent, although we preferred silicone oil, but considering one posterior break, only gas would have been sufficient for this particular case. Thank you.
Very nice case presentation, Dr. Dhaivat, with a good surgical outcome. But there is a question in the chat box for you. They're asking that why were the residual, those fibrovascular membranes left at the end?
Yeah, so that's what I said, that we tried to remove almost all the possible traction, but those, the remaining probably for the membranes which were there around the arcade, it was not threatening, or it was not, creeping up the macula. So the overall, the architecture was not disturbed, what we found. So we did not try to remove all the, but just clear it as much as we could. So that's what I meant, that in diabetic and this kind of TRD cases, we can have our best to remove all the possible traction, but almost 100% is not possible at times.
Yeah, this was a very well done surgery. And yeah, as long as we are segmenting and remove those tangential tractions, and some membranes can be left back. And if we have a break which has been created, we also tend to be extra cautious to prevent more or multiple breaks from developing. Dr. Chitaranjan, could you discuss the different techniques of membrane dissection in diabetic vitrectomies?
Okay. So conventionally, the membrane dissection has been described into segmentation, delamination, and en-bloc dissection. We saw in the video that Dhaivat nicely showed the segmentation, which basically is cutting the sheet of the fibrous membrane in between the attachment to the retina. He showed it very nicely. Also, he showed the en-bloc dissection. En-bloc means we remove the fibrous sheet along with the posterior hyaloid. So delamination is another thing in which we just sever all the attachments of the fibrous membrane to the retina. So, but honestly saying, most of the times it is a combination of all these three, and it's not exclusively one procedure, and it is customized as per the convenience of the surgeon and as per the need of the case, the particular case. And another thing is bimanual surgery. In that, a 25 gauge self-retaining chandelier illumination is put, and the surgeon can use horizontal seizures or peak or cutter, vitrectomy cutter. And especially bimanual surgeries are reserved for little challenging cases like a combined RJ or a thick fibrous membrane in the posterior bone. So these are the conditions where bimanual surgery is preferred. And if there is any break, if we saw any break, we must be sure, doubly sure that there is no membrane adjacent to the break. Otherwise, there will be again traction and detachment. So these are the points we should take care when Ashish.
Yes. We'll move on to the next point as to is there a role of putting a scleral band in diabetic vitrectomies?
So this would be right. Should I take the question that Ashish?
Yeah. Dr. Chitaranjan, you can answer.
Yes. So by and large, almost like most of the cases of diabetic vitrectomy, be it TRD, combined RD, vitreous hemorrhage, with the advent of high-end vitrectomy machines and minimally invasive vitreous surgeries and 10,000 cutter and high-end machines, mostly we do personal vitrectomy. But yes, in certain special situations, we may need a band additionally. So those situations may be where we are having an anterior severe proliferation of the membrane, or when we are having a combined RD with a hole in the anterior retina towards the vitreous space. But again, as we know, diabetic retinopathy and these tractions are more of a posterior pole disease. These occurrences may be less often encountered, and if we encounter this, then we may need a band, maybe a 42 band, preferably than a 240. And in the presence of a hole, we may go for a buckle additionally. Yeah, these are the situations.
Okay, would any of the panelists like to add a point on this?
Yeah, Ashish, can I add a point on buckle?
Yes.
When there is an anterior hyaloid proliferation, that would be relatively, I feel that it may be a condition wherein putting a buckle is likely to put the patient to a risk for a neovascular glaucoma. So when there is an isolated anterior hyaloid proliferation, it may be difficult. It's better not to put a buckle. The second point is most of the patients, when the buckle is put, generally when there is an intraoperatively peripheral break, particularly in a phakic patient wherein you are not able to clear the vitreous despite it's an unanticipated break. So most of these situations wherein you have a peripheral break, which you will not be able to do a good dissection of the anterior edge of the break, maybe those are the conditions wherein we may put a circumferential buckle or a isolated segmental buckle to support that particular part of the retina which cannot be treated with laser. Apart from that, I think the panel, in the chat box, I saw a few questions regarding why were the membranes left. I think generally the tendency is to remove the entire membrane and end up having more breaks. I think the one when Divakant saw when Vasavada saw one kind of a break temporarily, that's when he became cautious and he felt that further break may decrease the possibility of a visual outcome. The question is like when he had made such a good dissection of the membranes at the posterior pole, he could have still handled those membranes. Maybe that break which he had temporarily might have limited the further dissection of the membranes. Regarding the way the membranes have been dissected, I felt I would rather approach this membrane temporarily exactly at the area where he had break. There was a large enough space below the area where the membrane was lifted, and there is a small kind of a vessel which was, if you can see that video, particularly at the temporal edge of that membrane, superior temporal edge of the membrane, there is enough space. I would unfold that membrane from the macula first and then address the posterior pole, and with a gentle meter traction at the disc, tangential meter traction at the disc, then lift the membrane. Bhavik mentioned in the chat box saying that lifting the membrane from the disc can be a easy step to remove the entire membrane. But sometimes if your membrane dissection is not good enough, just lifting alone from the disc sometimes can cause torrential bleeding, hampering the dissection of the other membranes.
Dr. Ashish, can I add something?
Yes, sir.
Yeah. So as you are discussing buckles, so see, it has to be planned. So because we have seen proliferations extending from in a diabetic, and these are very, very advanced cases where you see proliferation from posterior pole and extending in the periphery. So in those cases, probably yes, you can judge and probably put the buckle pre-hand itself. In those cases also, because we usually do scleral tunnels and do a sutureless buckle, so we do not suture it. So one more thing which I do is that I tend to understand the anatomy. Okay, probably this may be an area where I would not be able to peel because it's so anterior, or if I peel there may be more ifs and buts of causing further complications, things like that. So I would avoid making tunnels, but I would make two tunnels adjacent to that area, so that if at all I need to put an additional solid silicone buckle over there, I would put it over there, and then it can act as a like complete sutureless buckle itself, not the band buckle but the buckle itself, because the two ends of that tunnel would push the buckle radially inside, and then that can be helpful. So these are the scenarios where I would have planned pre-op. Means if I see proliferations, and if I see proliferations very anterior, and cases like Eales disease where proliferations are known to occur more in periphery rather than in the posterior pole. Other than that, if, as sir was telling, that if we have a break intraoperative, then the question arises when to put the buckle, because if in a saline filled eye you have to suture and then put the buckle, because saline can leak very easily. But again, doing under air is a very high risk to take, because considering that the air can also leak, and then formation of the globe would be very difficult. So ideally, if you're putting, because once you have not planned and then you're wanting to add a buckle, then doing when you are just finished the membrane dissection and the final point, you suture all the ports and then fill the eye with saline or probably a PFCL, because even if it comes out, it may be a little slow, then you can do it. Otherwise, the last option would be that you finish all the surgery and then do it under oil. But then once you are doing under oil, it has to be little underfill so that your buckle indent can be taken care of, because you may tighten the buckle later on. And once you're doing under oil, the slippage chances occurs if you use sleeve. So ideal would be to use a cleavage knot. Yes, as sir was also mentioning, that we have to be careful in cases of CRDs, because anti-segment ischemia is known in such cases, and already the perfusion is less, and then very high buckle should be avoided. So, Ashish, these were my points.
Yeah, so as in the chat, the discussion going on is silicone oil versus air or gas tamponade. Would any of the panelists like to add their views?
Regarding the oil, I think everyone, when they start their vitrectomies, particularly diabetic vitrectomies, end up putting more oil. And in most of the conferences, we hear from most of the people saying that oil is bad, and when possible, try to put a gas and or maybe a saline or a gas as a tamponade. But we always, as beginners and as people, as we get experience, we keep finding a reason not to put gas. We always try to find a reason to put silicone oil and end up putting a silicone oil, and we are happy. But there are certain situations wherein silicone oil is mandatory, like if you have an one-eyed patient who has got an advanced diabetic retinopathy and you have created certain breaks in the retina, and if you have a patient in whom you might not have been able to remove the entire peripheral vitreous, a patient who is likely to recurrently bleed, particularly a patient who's got a renal patient who's on dialysis and always using heparin for dialysis, and you have done a couple of vitreous lavages and still you are not able to control his recurrent bleeds, then maybe silicone oil is also an option in these group of patients. However, I would restrict my tamponading agent on as gas for only certain group of patients, particularly if I've cleared all the membranes, particularly the membranes near the break, and if I've had no breaks, or if I've had breaks in one or two single or in the similar quadrants, where the particularly the superior quadrants, then maybe gas is a very good tamponading agent, because all the silicone oil related complications can be avoided. But silicone oil is mandatory because in some group of patients, particularly the one-eyed patients, and it gives a very good clarity of the media, whatever said and done. And particularly in private practice, when you don't want to answer the patient based on at least if you put a silicone oil, definitely the patient is likely to see something the next day, or else if you put a gas, the patient is not able to see anything from day one, and subsequently the patient ends up having recurrent vitreous hemorrhage. He may also think that the surgery might have not gone on well. So these are the other practical things which you face in private practice. But as you put the silicone oil, the media remains very clear, and you can see what is going on in the underlying retina. And the choice gradually, as you become experienced, I think you end up using more gas than the silicone oil, because you see more of the silicone oil related complications.
So, in the patients with glaucoma with diabetic retinopathy, what would the panel prefer?
Shall I answer?
Yes, sir.
Yeah. So finally the retina has to attach. So the answer is that. So there is nothing else, because if the retina doesn't attach here, nothing else which matters at all. So the question arises, as sir was also discussing, is initially because you need to get the patient confidence, and in a private practice that's foremost important. And resurgery is like being in an institute. Yes, you can have diffuse heme and then you can do vitreous lavage and then tell the patient, okay, this is nothing, this is very usual. But otherwise, in a private practice, the things are different. And yes, once the patient sees post-surgery, then he is also confident. So oil, gas, those are all individual. But assessing bleeders at the end of the surgery, that's the foremost important. So ideally, if you're operating in a high pressure, decrease it, wait for 5 minutes, 10 minutes, because diabetes, once you have cleared the membranes, also the diffuse heme is a big problem which happens later on. So if you want to keep it under air or saline or whatever, so you have dissected very well, no breaks, nothing. But after this, once the surgery is over, spend some time on hemostasis. Check for bleeders at low pressures. Means you must be operating at 30, so it may not be bleeding. But once you decrease the pressure to 20, then you would see that there may be some flimsy bleeders which may come up. So you have to wait. You have to let them adequately hemostasis before you close the case or remove the port, because otherwise oil is just giving you a pseudo confidence that the next day I'm seeing. But there can be hemes. We have seen cases where we have put oil and the whole heme has come into the anterior chamber, and then we had to do an AC wash, and the oil has come into the anterior chamber, then the oil completely from the posterior chamber has come out. So all those things happen. So it's a pseudo confidence which we have with the oil, but our membrane dissection and hemostasis is adequate way to answer what the option would be. If we have a break, and as sir told, one-eyed and patient's confidence is low, things like that, we can opt for oil. But otherwise, it's a very personal choice at the time. So there are other. Sorry, Dr. Ashish.
Yes, sir. Go ahead.
So there are other questions regarding the recurrent vitreous hemorrhages. So we need to understand the cause of recurrent vitreous hemorrhages in cases of diabetes, because anterior hyaloid proliferation or reproliferations or anterior vitreous, sometimes what happens, as I was telling, that usually the superinasal vitreous may be still not peeled, or there may be a tag of vitreous which is extending a little posterior, which we may have missed because most of other membranes we have removed. So sometimes what happens is there can be a spontaneous PVD induction, which there can be bleeders, or there can be proliferations, with minor proliferations which may have missed. Those can be reasons. So because we need to identify, if there is no view, then doing UBM, check for neovascularization, check for pressure. If the pressure is low and a late diffuse heme, then we are looking at something which is called as anterior hyaloid proliferation. If you do not have an UBM, check for neovascularization of iris, retraction, and if it's an aphakic, probably complete retraction and closure of your PI. So that is some signs which should give us a clue that there is anterior proliferation which is occurring. And if you do not have, means if you have a facility of UBM, get a UBM done in all cases of your diffuse heme after your surgery, not immediate, the late surgery, like you've done the surgery and then there is a diffuse heme for 1 month, then that's different. But if it's happening 1 or 2 months later, because anterior hyaloid proliferations or neovascularizations are common. Very rare, there are certain papers where they have utilized anterior cryo and anti-VEGF, but in those cases, UBM was not showing very gross anterior hyaloid proliferations, or to say probably maximum 1 or 2 clock hours, or only at the site of your ports. So in those cases, you can try that. But then finally, most of the studies have proven that doing a vitreous lavage and doing additional laser helps in such cases. And again, the option of in recurrent vitreous hemorrhages or delayed vitreous hemorrhages, again, we have to discuss with the patient, because intraoperatively, we would not find any specific bleeders, and probably again, we may opt for either gas or something, because it's not that oil is the holy grail. So as we know, oil also comes with its pros and cons. So something which one Dr. Sarvanan mentions is that if we have this recurrent vitreous hemorrhages, then we can do a PI, even in a pseudophakic, do a PI, so that whatever the diffuse heme is there in the vitreous would come into the anterior chamber and get absorbed faster. That was one proposition. And yes, if you do not find any ocular causes, then probably doing a carotid Doppler to understand if there is any ocular ischemic syndrome association with it. So that's it from my side, Dr. Ashish.
Dr. Diyvansh, sorry, is it the port site neovascularization that you are telling the same thing as the anterior hyaloid proliferation? On terminology, they tell port site neovascularization.
So port side, the proliferation is not significant. So the anterior hyaloid proliferation is where we find a whole fibrous proliferation in the pars plana, which extends into the pars plicata and over the retina also, which would cause peripheral retinal detachment. So minor port side proliferations are known. So even in cases of macular hole or ERMs, we would get that.
Okay, thank you.
I would like to ask Dr. Dhaivat's views, any final comments regarding this case or diabetic vitrectomy in general?
In general, like as running in chat box, I also prefer to for air or gas as a tamponade, because on the longer run it gives a better visual acuity compared to oil. But many of the times when this kind of TRDs or you find tiny breaks are there while doing vitrectomies, especially in the inferior quadrant, those are the cases while when we can end with the siliconol, because you get a post-op vision as someone said. But otherwise, all said and done, oil or gas would be a better option for tamponade in diabetic vitrectomies. And regarding the ILM peeling, as the poll was out, so whenever we are going inside, we try to do as much as we can. So you just try to remove all the possible traction, because diabetics is always, vitreous is always sticky. So peeling the ILM would be a better choice any day. That is my goal.
Ashish, one last question, if you can permit.
Yes, sir.
Yeah, I just wanted to know because when we were doing fellowship, our mentors always used to have a separate set of instruments, both for membrane peeling, and they were all called by their names. It is their forceps, it is their scissors. I just want to know how many of us still have our own set of scissors, horizontal scissors, or kind of a pick forceps which we use for surgery, or we just go with only the cutter. Diyvansh.
Sir, if the case is very difficult, we would ask for sir's instruments.
Okay. All right. That answers it.
Okay, so I thank everyone for spending time and attending this session. And diabetic vitrectomy is a very big topic, and I'm sure we could have multiple sessions on this in the future. And we had some great points discussing the various cases. And thank you for attending, and looking forward to discussing and meeting everyone in the next session.
Thank you.
Thank you all. Thank you.
Thank you, Ashish.
Thank you.
Thank you all. Yeah.